All right, we should be recording. So tonight I'm going to do a review of the thorax. Okay, so for those of you that just logged on, I shared the link to my Google Drive and then the link to sign in again. So let me know if you have any issues with that. The slides for tonight are under the review folder, and after we're done here tonight, I'm going to post the slides that you'll be seeing me go through that have all the answers to them. And then also beneath a lot of the slides in the presenter notes, I have notes for myself. Yeah, thank you, Brandy. Yeah, make sure you guys look at the bottom. It says all of our names, so make sure you get the right tab. What was I saying? So under a lot of the slides, once I upload this answers version, you'll see notes that are just for myself and then also for you guys. So on a lot of the slides that are like more involved or more confusing, or some of the practice questions that are more confusing, I have like a longer explanation. I just didn't want to put all of that on the slide because, it's just too much. So yeah, when we're done, I would encourage you to download the answers version once I post it. All right. So I didn't realize until I put this together that doing all of the thorax may have been a little bit ambitious because I think there's like 130 something slides. So I'm going to be going fast, but feel free to stop me anytime you have a question. All right. So most of the content is if you've been in my sessions in the past, it's a repeat of stuff that you've already seen. But I think just to refresh, since you've had histo and MFM and all that, I'm just going to refresh everything and try to bring it back. Okay, so we'll start again with the first lecture, which was the thoracic wall. All right, and feel free to, unmute yourself and ask the question or type it in the chat box. Either way is fine with me. All right, so ribs 1 through 7 are true ribs. Ribs 8 through 12 are false ribs. We can further divide all our false ribs into ribs 8 through 10 and floating ribs 11 through 12. So ribs 8 through 10 are special because the costal cartilages articulate with the superior costal cartilage. So if we count down 1, 2, 3, 4, 5, 6, 7, so 8, 9, and 10 are articulating with the costal cartilage of the rib above. And then ribs 11 and 12 are called floating ribs because they don't have any anterior connection with other ribs or with the sternum. Okay, so why is the sternal angle an important clinical landmark? So the biggest thing to know is that you can use the sternal angle to palpate rib 2. Okay, so starting off nice and easy here, the second costal cartilage can be located by palpating the, go ahead and type your answer in the chat box. Right, B, the sternal angle. Okay, so on this slide, two big things to know here. First, this picture, you want to be able to describe each rib's articulation with the thoracic vertebra. So, of course, this is Dr. Hermes' picture. She uses rib 5 as an example. So rib 5 is going to articulate with the vertebral body above and the vertebral body at the same level. And then also you want to know that the tubercle of the rib is going to articulate with the costal facet on the transverse process of corresponding vertebrae. So what that means is rib 5 is going to articulate with the costal facet on the transverse process of T5. Okay, so 2 important points. The rib articulates with the thoracic vertebral body above and at the same level, and with the costal facet on the transverse process of the vertebra at the same level of that rib. And then over here, we just have, the important landmarks on the ribs. So you want to be able to identify the tubercle, the head of the rib, the costochondral junction, and then the costal groove here where your neurovascular bundle lies. So my question for you guys is, if they were to set out a rib on your lab practical, what is one kind of hard and fast way that you could tell if that was a left rib or a right rib? Say you weren't able to touch it, you're not able to pick it up. How are you going to know, is that a left or is that right? Anybody? That's probably not the safest way. So what I would say, if you're not sure if it's left or right, look at this costal groove. Yeah, the angle is a pretty good clue, but I would say the safest way to tell is by this costal groove. So the costal groove should be on the inferior surface of the rib, or the inferior margin. So that should be kind of a fail-proof way to tell if this is left or right. Okay, so question. A 45-year-old female was a passenger in an MBA where she fractured rib 5 on the right side and the structures with which it articulated. Which of the following structures would most likely be damaged? And take a look at your answers and type your answer in the chat box. Yep, good. It looks like you guys have got that down. So the answer would be D, transverse process of the 5th thoracic vertebrae. So the rib's either going to articulate at the same level, the transverse process at the same level, the vertebral body at the same level, or the vertebral body one level above, which would rule these other 3 out. Okay. I don't remember being tested on any of these last year, but just in case, remember you have an intra-articular ligament between the head and the vertebral bodies, and then a costotransverse ligament and a lateral costotransverse ligament. Okay. This slide is very important. You're probably going to have more than one question coming from this slide. So I made this as, just a summary. So you guys can stay on this slide and I'm going to go to the next one and kind of talk about it. Okay, so the first layer here is your external intercostals. So that's the number 1 here. It's running from the rib tubercles to the costochondral junction. So all the way back here towards the front, it stops right here, and then it becomes the external intercostal membrane. So that's number 2. from the costochondral junction to the sternum. And then number 3, your internal intercostals. So that's the layer below the external intercostals. The internal intercostals can be divided up into an interosseous portion and an interchondral portion. So interosseous meaning between bone, and interchondral meaning between cartilage. So the interchondral portion is going to be from the sternum to the costochondral junction, and then the interosseous portion is from the costochondral junction wrapping all the way around the back to the angle of the ribs. And I believe last year they either tagged, I want to say they tagged the internal intercostals. And so how they did that is they lifted up this first layer here, so the external intercostals, and then you could see the fiber direction of the internal intercostals. So that fiber direction, we call it hands and gloves. So if you imagine, I know you guys can't see me, but if you imagine, your fingertips pointing up towards the ceiling and you're trying to wrestle a glove on, okay, so that direction. And then external intercostals are going to be hands and pockets. So if you stick your hands in your pockets, those fibers are running that direction. And that's how you're going to tell the difference between the two on the practical. Let's see. Number 4 is the internal intercostal membrane. You can kind of see it in the back here. So that's from the angle of the ribs to the vertebral column. So remember, we have external intercostal membrane in the front and then internal in the back. And then number 4, your innermost intercostals, those are just in the lateral thoracic wall. And then here in the front, if you can imagine that you're standing behind somebody right now and you can see through them to the anterior thoracic wall, you have the transverse thoracis muscle. So starting from the xiphoid process and inserting on ribs 2 through 6. And then the last important thing to know about that chart is going to be the function of each of these muscles. So I get a lot of people ask me, like, how in the world do you remember all this stuff? Usually it's by learning one thing and then remembering that, well, everything else must be the opposite or the other thing. So if you can just remember that external intercostals and the interchondral portion of the internal intercostals are involved in inspiration, then any of the other thoracic wall muscles you're asked about, those are going to be expiration. So you're learning all, 5 or 6 functions by remembering 2. Okay. This slide, so last year I was like, oh, this is stupid, who cares? But it actually ended up being a test question. So make sure you understand this. So the sternum, and this comes up again eventually in OPP when you do ribs. So the sternum acts as a pump handle, meaning that it's going to increase the AP diameter. So AP means anterior posterior. So the sternum is going to come out anteriorly, so your front to back diameter is going to increase, and we call that a pump handle motion. And then the ribs have a bucket handle motion because they increase the diameter of the thoracic wall transversely, so out to this side. So pump handle, bucket handle. All right, next question. And FYI, if it looks like this, it means I wrote it. So if you feel like it was poorly written or there's two right answers or something, like, let me know. Okay, so a 60-year-old male patient recently diagnosed with COPD presents with prolonged expiration. The attending asked you to name a muscle of the thoracic wall involved in expiration. Which of the following muscles would you give as an example? I encourage you guys to try not to look back at the slides just so you can kind of give yourself an idea of like, what do I actually know? And, use this time efficiently. All right, so the answer is B, interosseous portion of the internal intercostals. So A and C are going to be involved in inspiration, and then transverse is abdominis. So that's an abdominal muscle. So, if you gave your attending, it is involved in expiration, but, it's not part of the thoracic wall. Okay. Now, this picture should help you understand that depending on, say if you're stabbed or if you just point to a region of the thoracic wall, the layering of the muscles are going to be different depending on where each layer stops and starts. So when you look at this question, pay attention to this picture, and that should help you out. So your patient is a 25-year-old male medical student who presents with a pneumothorax and stab wound to the right fifth intercostal space adjacent to the sternum. His friend says they were at the bar celebrating the end of their first block exam, and as they were walking to the car, the patient was stabbed by a man who left the scene. Which layers of muscle and or membranes did the knife pass through to cause the pneumothorax? Okay, so I think most of you, I'm getting a lot of C's, I'm getting a lot of D's. Okay, so the answer is C, and so I wrote this question. So he was stabbed in the right fifth intercostal space adjacent to the sternum, so that means right next to the sternum. So if you look here, this outer layer, I don't believe it's, oh, here it is, yeah. External intercostal, so right here's the sternum. Right next to the sternum would be the external intercostal membrane, the internal intercostal muscle, and then the transversus thoracis. So if he was stabbed right here, this is the path that the knife is going to take. D is very close. The only thing that makes this wrong is, remember, the external intercostal membrane runs from the costochondral junction to the sternum. And from the costochondral junction on around back is the actual muscle. Does that make sense to everybody? Okay. Got one yes. Okay, good. So I don't know if you guys have heard, but Dr. Hermy has a reputation for stabbing questions. Okay, and this is a good way that she could do it because this would test if you know where each layer of the thoracic wall kind of like stops and starts. So, like for example, if he was stabbed at the mid-axillary line, it would travel through the external intercostal, then the internal intercostal, and then the innermost intercostal. So if he was stabbed right here, you can see what the path would be. All right. So very, 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 very important slide. And that's because you need to know that this neurovascular bundle is on the inferior margin of the rib. and the mnemonic we use is VAN. So I think, it's pretty much always going to appear in this order. So vein, artery, and nerve. Okay, and I didn't explain the needle because I want to do that with this practice question. Okay, so you're about to perform an intercostal nerve block in the 5th intercostal space. Where should you insert the needle to administer the anesthetic? Okay, so your 5th intercostal space is between what two ribs? Correct. So where are you going to put the needle? So I'm talking about in relationship to the rib, not the space. Yes, 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 yes. So C is the correct answer. All right, so let's try to understand this. Okay, so let's pretend that this is the 5th intercostal space. So this is rib 5, this is rib 6. To perform the block, you want to put the needle in the inferior margin of rib 5 because that is where that neurovascular bundle is located. Does that make sense to everyone? Sorry guys, I just got disconnected for some reason. Okay, let's jump back in. Okay, can everyone hear me okay? Okay. Okay, so when you're performing a nerve block, yeah, superior to rib 6 isn't an option, correct. So when you're performing a nerve block, you want to hit that bundle. Okay, so that's why the inferior margin of rib 5 is correct. Okay, and I think this is going to become more clear. I have another practice question that I think may clear this up. Okay. Yes. Okay, well, you want to be close to it, yeah. You want to be close to it so you can anesthetize it. Okay, so you're called to perform a thoracentesis to remove fluid from the pleural cavity. If you are to avoid injuring the lung or neurovascular elements, where would you insert the aspiration needle? Right. So D, the bottom of interspace 9 in the mid-axillary line. So is that making sense? So if you want to remove fluid, you're trying to avoid the neurovascular bundle. So you want to stay away from it. If you're trying to anesthetize that nerve, you want to, hitting it was probably the wrong word, sorry. You want to get as close to it as possible. That way the anesthetic is reaching the nerve. Okay. All right, let me know if you guys have any questions about that. I put those two questions together to hopefully clear that up. Okay, so easier question. The thoracic wall is innervated by correct B. How could I change B to also make a correct answer? Like, what could I put in place of B to also make it correct? 3 words. So not dorsal primary rami, but ventral, right. So if you were to see ventral primary rami as an option, that would make this question a little bit tougher. And then, there would be your correct answer. So I know for me, like the whole dorsal ventral primary rami, I stayed confused about that for a long time. But, the sooner you can get that straight in your head, I think the better off you'll be. Okay. Okay, so for the previous question, is there any significance between midclavicular versus mid-axillary? Yes, because, hold on. Yes, so mid-axillary would be the correct answer because the pleura is going to extend down further at that line. Does that make sense? And we'll get there with that when we get to the lung stuff. Okay. Okay, so back to this question. So ventral primary rami would also make this correct. Just as a review, so if they use this as an answer on your test this time, what is the only function of dorsal primary rami? So there's 3 things. What do the dorsal primary rami do? Not the dorsal root, the dorsal primary rami. Do you guys remember from the first block? Be more specific. So you would agree if I said intrinsic, yeah. Intrinsic back muscles. What else? So that's one thing. 2 more. So the skin of the back and then the joints between vertebrae. So those 3 things. Intrinsic back muscles, skin of the back, and joints between vertebrae. Okay, what does the lateral pectoral nerve do? Correct. What about medial? So lateral does pec major. Medial does major and minor. I thought I saw Johnny was in here. Johnny, what does the thoracodorsal nerve do? I saw you posting about this on Facebook. Is Johnny still here? Yes. Latissimus dorsi. Okay. Okay, so moving on. I believe last year they tagged the internal thoracic artery. So the subclavian artery on either side gives off the internal thoracic, which supplies the anterior thoracic wall, and then it splits into a superior epigastric and a musculophrenic. And then your anterior intercostal arteries, so running along the anterior wall, the upper 6 branch off of the internal thoracic artery, and then the lower 6 branch off of the musculophrenic artery. Okay, so superior epigastric, it is a Hey you guys, I'm so sorry. Zoom keeps kicking me off. If this happens again, I'm probably just going to reschedule for tomorrow night, okay? All right, so again, I apologize about that. All right, so superior upper gastric, musculophrenic. Can everyone hear me okay? Thank you. Yeah, Zoom is apparently not my friend tonight. Okay, so thank you guys for hanging around. Like I said, if it happens again, I'm not coming back, okay? We'll just reschedule. Okay, let's see. What was I going to ask you guys? Okay, so superior epigastric is coming from the internal thoracic. Where is the inferior epigastric artery coming from? Right, the external iliac artery. So make sure, just make sure that you know that. That's something that's difficult to remember and something that they might ask because it's not really intuitive. So superior epigastric from the internal thoracic, and then inferior epigastric from the external iliac. Okay, let's keep rolling before I get kicked off again. Okay, so on this slide, so now we're looking at the posterior body wall, and the posterior intercostal veins are draining into the azygous system of veins. And then the anterior intercostal veins drain into the musculophrenic vein or the internal thoracic vein. Okay, and then you want to remember that your azygous vein is over here on the right, and then you have a hemiazygous and an accessory hemiazygous in some people. So I believe what they did last year is they showed the hemiazygous crossing over the vertebral column, and then they tagged it. So you could see it crossing over and draining into the azygous, and it was down here, so you would know to call it hemiazygous. Okay. So intercostal nerves, so we can also call these ventral rami of T1 to T11 spinal nerves, and then the ventral ramus of T12 is known as the subcostal nerve, and it's going to lie inferior to the 12th rib. So these intercostal nerves are going to give off lateral and anterior cutaneous branches. So the intercostobrachial nerve is special because it's the lateral cutaneous branch of T2, and it joins up with the medial brachial cutaneous nerve to supply the medial side of the arm. So where is the medial brachial cutaneous nerve coming from? And this is reaching back to first block, your first anatomy exam. So medial, yeah, Johnny, you're right. So medial brachial cutaneous is coming from the medial cord. And cardiac pain is often referred to the medial side of the left arm because, so we have sympathetic fibers. So preganglionic sympathetic fibers are traveling through the ventral root. And then remember, they go through the white rami communicans to reach the sympathetic chain ganglia. They synapse there and exit as postganglionic sympathetics through the gray rami communicans. And now they're traveling out towards the body wall. So we have those fibers, and then we also have somatic pain. So we have sensory information from the medial brachial cutaneous traveling, through here from the medial side of the arm, and then, it enters here and goes to the spinal nerve and to the dorsal root ganglion. And so the fact that these fibers are crossing paths means that information can, the best way I can describe it is it's mixed up. And then you have pain that's intended, that's a visceral pain, that's being relayed to the medial side or the medial aspect of the left arm and causing pain down that left arm. Okay. Okay, so I kept this question in here because it's a good one. This was, in like this first set of slides. So a 22-year-old patient received a stab wound in the chest that entered the intercostal brachial nerve. Which of the following conditions results from the described lesion of the nerve? Where is medial brachial cutaneous going? Is that going to the lateral aspect of the arm? Yeah, you guys both said D. Yeah, you're correct. Okay, so B isn't correct because we're talking about the medial aspect of the arm, so medial brachial cutaneous. There's no like somatic motor fibers in the path we're talking about. And then loss of sensory fibers, yes, this one is correct. So absence of sweating on the posterior aspect of the arm, yeah. So absence of sweating on the posterior aspect of the arm. So although, you are getting postganglionic sympathetics to the medial aspect of the arm, because this says posterior, that means it's not correct. And then E is not correct because damage to sympathetic preganglionic. So sympathetic preganglionics, they synapse in the sympathetic chain and then head out as postganglionics. So your injury would be to postganglionic fibers. Okay, so the correct answer would be D. All right. So the diaphragm, you want to know that it's innervated by phrenic nerves, and then blood supply by superior and inferior phrenic arteries. And then the structures traveling between the thorax and abdomen pass through the diaphragm. Okay, so the three big ones to know, and this is a helpful mnemonic. So I8 10 eggs at 12. I8 refers to the fact that the IVC travels through the diaphragm at the level of T8. 10 eggs, esophagus at the level of T10, and then at 12, the aorta at the level of T12. Okay, so what is traveling with the IVC, and what is the name of that hiatus? So you want to know these three, right? The caval hiatus, that's correct. And what's running with it? I believe this was in Dr. Dudzik's lecture. So I'm just trying to, help you guys make the connections here. Anybody? Okay, so your right phrenic nerve is running with the IVC through the caval hiatus. Does anyone know what the left phrenic nerve is doing? So it's just passing through muscle. Correct. Yeah, that's right, Clarissa. Okay, so remember IVC with the right phrenic nerve through the caval hiatus. Okay, what is the esophagus traveling with and through what hiatus? Think about what innervates the esophagus. And if an esophagus was to travel through a hiatus, what would you call it? Yes. So anterior and posterior vagal trunks, and then through the esophageal hiatus. Yeah, if you want to be more specific, you would say anterior and posterior vagal trunks making up the esophageal plexus, and it's passing through the esophageal hiatus. Okay, the aorta is traveling with what two structures and through what hiatus? This one's a little bit tougher. Yeah, thoracic duct is one, and azygos. Right. So thoracic duct and azygos travel with the aorta through the aortic hiatus. All right. Does anybody need me to repeat anything? Let me keep going. Okay. So pleural cavities. So on this slide, you want to know the difference between visceral pleura and parietal pleura. So anytime you hear parietal, where does the right? So the left phrenic, that's just piercing muscle. And the right phrenic is going through the caval hiatus. Yeah, no problem. Okay, so pleura of the lungs. Anytime you hear the word parietal, it's referring to the body wall. So we have parietal pleura, and then visceral pleura. Visceral, means organ, so it's in contact with the surface of the organ. So parietal pleura versus visceral pleura. What they could do is within the donor, they could scrape some of the parietal pleura off the body wall and tag that. Okay, so just be prepared for that. Then also you want to know up here is cervical pleura, costal pleura. So costal means ribs. So like lining along the surface of the ribs is your costal pleura. Mediastinal pleura is near the mediastinum, and then diaphragmatic pleura, of course, along the diaphragm. And then also important, phrenic nerves are getting mediastinal and diaphragmatic pleura, and then costal pleura are intercostal nerves. And then this cup-like dome up here formed by the cervical pleura, that's the copula. So you want to be familiar with this term here, or cupula. I don't know exactly how to say it. Be familiar with this word. Okay, nice picture out of Dr. Hermes' slides. Again, just showing you where the different types of pleura are. Okay. Another question. So you head out for a drink after another crazy block exam and find yourself in a knife fight on the streets of Knoxville. Since you were unprepared for city life, your attacker stabs you and the knife blade enters immediately superior to the upper edge of the right clavicle near its head. The ER physician is one of the best in the country because she graduated from LMU DCOM and determines you have a collapsed lung after disruption of the pleura. What portion of the pleura did the knife likely penetrate? Right. Looks like everybody's got it. So D. So that's formed by the cervical pleura, so up near the clavicle. All right. Okay, so two important recesses. The first one is the costodiaphragmatic recess, and that's this one right here where fluid likes to accumulate. And then number two, costomediastinal recess, here in the cardiac notch. I want to say, so I don't know if they did this on your all's practical, but you know how they can put images up on the TV screens in the lab? So they had an image, and it had an arrow pointing right here, and it asked you just basically what that was, like what's the arrow pointing to. So you just needed to know that was the costodiaphragmatic recess. So that should be like, if they did something like that, that should be a really easy point. Okay, so you're caring for a 68-year-old male who has copious amounts of fluid in the left pleural cavity due to acute pleurisy. When you examine him as he sits up in bed, where would the fluid tend to accumulate? Yes, so costodiaphragmatic recess. Everyone good with that one? I'm gonna keep flying here. Okay. So whoever had this question earlier about the mid-axillary line, hopefully this answers it. Okay, so this slide here, I don't remember. Yes, that's correct. I don't remember if this was tested so much in anatomy, maybe, but where I really remember it was OPP. So when you guys get to ribs, at least last year on our written exam, we had probably a half a dozen questions on the like borders of the lung and the pleura and the fissures. So just make a mental note that when you get to ribs and OPP, make sure you know this stuff. Okay, so a trick I came up with to remember this, the way that I did it, was 6, 8, 10, 8, 10, 12. So 6, 8, 10 refers to the margins of the lung. So in the mid-clavicular line, the lung extends to rib 6, in the mid-axillary line, rib 8, and then posteriorly it extends to T10 in the back. And then the pleura extends in the mid-clavicular line to rib 8, in the mid-axillary line to rib 10, and then around back to T12. So just remember 6, 8, 10, 8, 10, 12. And then where do you want to insert a needle for to remove fluid? So that's going to be in the 9th intercostal space in the mid-axillary line. So in the mid-axillary line, the inferior lung margin is at rib 8. So to be safe, you're going to put it in the 9th intercostal space because you want to be within the pleura where the fluid's accumulating, but you don't want to be too far up where you're hitting the lungs, and you don't want to be too far down where you're not getting inside the cavity. All right. So when inserting a chest tube, intercostal vessels and nerves are avoided by placing the tube where? Yes, above the margin of the rib. So hopefully this kind of helps clear up the confusion. So if you're inserting a chest tube to remove fluid, you want to avoid the intercostal nerve. If you're trying to anesthetize the nerve, you want to get close to it without hitting it so the anesthesia actually affects the nerve. Okay. Right and left lung. Okay, so this isn't too bad, I don't think. You definitely want to know all the differences between right and left lung. So, know that the right has 3 lobes, the left has 2. The right lung is going to have an oblique and a horizontal fissure. And a tricky question that they could ask you is which lobes are these fissures separating? So the horizontal fissure in the right lung, is separating superior and middle, and then oblique is separating, middle from inferior. And then you want to know that the left lung, just has a superior and inferior lobe separated by an oblique fissure. And then also, good to know, and I think I have an image in one of the upcoming slides, is the structures that are leaving impressions on the lung. And I have those listed here for you. Okay, so what is the difference between the hilum and the root of the lung? There's usually some confusion about this. So the root consists of the structures attaching the lung to the mediastinum. So the vessels and the bronchi, that's the root. The hilum refers to this area where they enter and exit. So the root's talking about the actual structures. The hilum is just referring to this area in general. And then also here in the left lobe, we have the lingula. Another important structure that you want to know, or landmark, whatever you want to call it. Okay, so another question. 75-year-old woman was admitted to a local hospital, and bronchograms and radiographs reveal a lung carcinoma in her left lung. Which of the following structures or characteristics does the cancerous lung contain? Yep, so I think everyone's got that one down. So lingula is on the left lung. Okay. So a 75-year-old patient has been suffering from lung cancer located near the cardiac notch. Which of the following lobes is most likely to be excised? Yes, so the answer is D, so superior lobe of the left lung. So, these questions are a good example of how they can make sure that exactly where these different landmarks are located on each of the lungs. Okay, yeah, and then here's a good picture to study from, right versus left. Which structures are leaving an impression in which lung? Okay. Okay, so the most important thing from this slide is that that the right primary bronchus is shorter, wider, and more vertically oriented compared to the left. And foreign objects are most likely to enter the right primary bronchus. So this was a question on our written exam last year, and then this was also a question on our cumulative anatomy exam. So something that you really want to know. Okay, a 31-year-old man was involved in a severe automobile accident and suffered laceration of the left primary bronchus. The damaged primary bronchus, what? Yes, so everyone's got that one right. It is longer than the right primary bronchus. Okay. A patient has a small but solid tumor in the mediastinum, which is confined at the level of the sternal angle. Which of the following structures would most likely be found at this level? Yes. So the bifurcation of the trachea, one important landmark identified by the sternal angle. Okay, and where that trachea bifurcates, what is that also called? Carina, correct. Good job. Okay, so one of your classmates messaged me over the weekend, and so I gave them this advice. So anytime there's a slide on limp, they tend to like glaze over it. Um, but I don't know if there was a question about limp on your first exam, but for us on every exam, there was at least one question pertaining to the lymphatic system. So there's generally only like maybe one or two slides on lymph, but if you do see one, I would make sure that you take the time to know it. Okay, so you want to commit 1, 2, 3, and 4 on this slide to memory. All right. So the mediastinum, that's the central portion of the thoracic cage between the two pleural cavities. So it's bound anteriorly by the sternum and costal cartilages, and then posteriorly by thoracic vertebral bodies, and it's bound laterally by the mediastinal pleura. All right, and then we can also divide the mediastinum into a superior and inferior mediastinum by the sternal angle. So another, thing we can identify based on the sternal angle. And then we can further divide the inferior mediastinum into an anterior, middle, and posterior mediastinum. And what does this is the pericardial sac surrounding the heart. Okay. All right, so I'll leave this slide for you guys. So this is just showing the contents of each part of the mediastinum. Like I've said before, don't try to rote memorize this. If you know your relationships well and how the anatomy is layered in the thoracic cavity, then you should be able to like reason through any sort of question about what's located in the posterior mediastinum or what have you. So just try to, learn the anatomy well, don't memorize the slide. Okay. So I put this slide in here to point out a little bit of a left from right difference. So the left brachiocephalic vein is much longer than the right, and it crosses over the anterior portion of the chest. And then also we have our Boston College sucks. So somebody explain to me the left from right difference pertaining to the aorta. So what is different about the left subclavian and the left common carotid compared to the right? Yeah, sorry. Okay, so yeah, I'll repeat. So somebody explain to me the left from right difference regarding the aorta. Yeah, the right comes from the brachiocephalic trunk. Yeah, so the left subclavian and left common carotid are branching directly off the aorta, and on the right side you have the brachiocephalic trunk. Okay. And then here, that's labeled for you. Okay, so this slide is here to point out, let's see, two things. Okay, so the ligamentum arteriosum, and then what is this nerve right here? Right here. And what am I about to say? What's an important branch coming off of it? You can probably guess what I'm about to point out. Yeah, the left recurrent laryngeal. So remember that wrapping around, posteriorly around the aortic arch. So last year on the lab practical, they tagged the left recurrent laryngeal nerve. So make sure that you can identify that in the donor. And then, maybe a little bit less important is the right recurrent laryngeal wraps around the right subclavian, just in case, you're curious what the right side is doing. Okay. And then don't forget this, BCS. Sure. So, okay, yeah, the right recurrent laryngeal is wrapping around posteriorly around the right subclavian artery to head back up towards the neck. But the one you really want to remember, and the one they always go after, is the left recurrent laryngeal near the ligamentum arteriosum. Okay. And here it is on the donor, if you haven't seen it yet. All right, and then we have phrenic nerves passing anterior to the root of the lung, and then vagus nerves passing posterior to the root of the lung. And, they definitely like to tag both of those in practicals. Okay. So this slide is going to be helpful in a practice question I have coming up. So a mnemonic that I like to use, it's called a duct between two gooses. So last year the thoracic duct was tagged. So if you see a structure passing between the esophagus and the azygous vein, so esophagus and azygous, so it's a duct or a duct between two gooses. And hopefully, if you remember that relationship, if you see something and you're like, I have no idea what that is, and you remember this, that if they do tag the thoracic duct, that you'll remember it. Okay, so where is the thoracic duct draining? Where does it drain? Where does it empty? Into what? Yeah, so it's going to empty into the junction of the left subclavian and the left internal jugular vein, so right up here. Okay. A 78-year-old patient presents with an advanced cancer in the posterior mediastinum. The surgeons are in a dilemma as to how to manage the condition. Which of the following structures is most likely damaged? Yes, correct, it's E. And you're just going to answer that by thinking about which structure is located most posteriorly. Right? I think you're thinking of accessory hemiazygous. As far as I know, most people have a hemiazygous, but it's the accessory that a lot of people are missing. Yeah, so answer this by thinking, which structure is most posterior in the thoracic cavity. All right, a 45-year-old woman presents with a tumor confined to the posterior mediastinum. This could result in compression of which of the following structures? So again, thinking of which structure is most posterior, and also which structure is actually located in the posterior mediastinum. No one's given me a correct answer yet. Okay, yeah, so B is going to be the correct answer. A lot of you are saying D. So the arch of the azygos is actually located in the superior mediastinum. So this one is pretty tricky, but this came out of BRS, so blame BRS, not me. Okay, so the heart, I'm going to have to pick up the pace here. All right, so surfaces of the heart, make sure that you know these. So anterior, mainly the right ventricle. Right pulmonary surface is the right atrium. Left pulmonary is the left ventricle. The diaphragmatic surface is mostly the left ventricle and also the right ventricle. The apex is the left ventricle and the base is the left atrium. Okay, and then why is the left pulmonary surface mostly the left ventricle? So it might be easy to think because the right pulmonary surface is the right atrium, that the left pulmonary surface would be the left atrium. This isn't the case because of the way that the heart is rotated and the apex is positioned at an angle to the left. So the left atrium is actually going to be in the back of the heart. Okay. Practice question. A patient involved in an automobile accident presents with a sharp object puncture of the middle of the sternum at about the level of the fourth or fifth costal cartilage. If the object has also penetrated the pericardium and heart wall, which heart chamber would most likely be damaged? So if you think about your surfaces, you can answer this one. Right, so the answer to this one is going to be the right ventricle. Good. Okay, so blood flow through the heart. I'm going to mostly skip this just for time's sake, but two important things to know that are easily confused. The pulmonary arteries are carrying deoxygenated blood, and then the pulmonary veins are carrying oxygenated blood. So one example of a place where this is different. Okay. And then also, this can be tricky on the exam, so don't be thrown off if they, say if you're only comfortable with calling, the right AV valve the tricuspid, don't be thrown off if they say right AV, or if instead of saying mitral, they say bicuspid. Make sure that you're comfortable with interchanging all of these names. Okay. So the pericardium of the heart, we have a fibrous pericardium and a serous pericardium. So the serous pericardium can be divided into a parietal layer and a visceral layer. And you could see the parietal layer here and the visceral layer here. So the parietal pericardium is fused with the fibrous layer of the fibrous pericardium. So if you're looking at the fibrous pericardium from the outside, you're going to call it fibrous pericardium. If you cut it open and you can see the inside, it's going to be the parietal layer of the serous pericardium because these two layers are fused. All right, and then two important sinuses, the transverse pericardial sinus and then the oblique pericardial sinus. And I have pictures of each of these here. So you can see the oblique pericardial sinus by just lifting up the heart. So if the heart is still in the donor and you lift it up, that's going to be oblique. But here, the transverse pericardial sinus, I put this in red because I'm pretty sure last year what they did exactly what they're doing in this picture, and they stuck a probe between this vessel here and these two vessels. Okay, so they stuck they stuck a probe between the inflow vessel and the two outflow vessels, and they said, what sinus are we in? So this is important clinically because they're going to clamp these vessels off for cardiac bypass. All right, let's do a question. In cardiac surgery, it is sometimes necessary to clamp off all arterial flow out of the heart. This could be done with the pericardial sac by inserting the index finger immediately behind the two great arteries and compressing them with the thumb of the same hand. The index finger would be inserted into which space? Right, so the answer is E. And what is the name of the two vessels that they would be clamping off? So go back to that picture, and what two vessels would they be clamping off? Right, the pulmonary trunk and the aorta. That's right. Good job. Oh, I think I just stole my own thunder. Yeah, okay, so we've already answered this one. Pulmonary trunk and the aorta. All right, a 23-year-old male injured in an industrial explosion was found to have multiple small metal fragments in his thoracic cavity. Since the pericardium was torn inferiorly, the surgeon began to explore for fragments in the pericardial sac. Slipping her hand under the apex of the heart, she slid her fingers upward and to the right within the sac until they stopped by the cul-de-sac formed. Yeah, I don't need to read it. You guys got this. So oblique sinus. That's the one where you lift up the heart. All right. So on this picture, be familiar with everything in red here. Probably the big ones they like to tag are the pectinate muscles, the crista terminalis, or the fossa ovalis. I kind of doubt they would tag the superior vena cava just because it's too easy. Okay, and then SA node and AV node, some people have asked me, no, you can't actually see that in the donor. So that's not something they could ever tag. Okay, then in the ventricles, trabeculae carne, they like that one because people confuse it with pectinate muscles. So rough wall in the ventricles, trabeculae carne, rough wall in the atria, or the right atrium, is pectinate muscles. Make sure you know tricuspid versus bicuspid valve, of course. The tricuspid valve has 3 cusps. The bicuspid valve only has 2. You want to know what your papillary muscles are, that they're anchoring the chordae tendineae, and the moderator band. Be familiar with that. And then this is a big one, the fact that the pulmonary trunk has a left, right, and anterior cusp, and then, the pulmonary semilunar valve, more specifically, and then the aortic semilunar valve has a left, right, and posterior cusp. Okay, so which statement is true of the right AV valve? All right, so just for time's sake, I'm going to keep going. Okay, so the right AV valve is open during ventricular diastole. So that's during filling. Remember that AV valves are going to be open, and then your pulmonary valves are going to be closed until the heart's ready to contract and push the blood out. So the pull of the chordae tendineae is actually going to close the valve. Okay. Which heart valve has leaflets described as anterior, left, and right? Correct. The pulmonary. I think everybody's getting that one. Okay. So I broke this slide down to just the main thing you need to understand right now is during ventricular systole, the semilunar valves are open, so blood is leaving the ventricles, and the AV valves are closed, so there isn't any reflux of blood back into the atria. And then during ventricular diastole, when the heart is filling, the AV valves are open until the ventricle is filled, and then the semilunar valves remain closed. So, of course, you're going to go into a lot more detail in physiology, but if you can just understand this little box right here for now, that's going to be like more than enough to get you by for the lecture exam. Okay, so which valves will be open during ventricular systole? Right, so aortic and pulmonary. And then tricuspid and mitral are going to be open during diastole because that's when you're filling. So the correct answer is A. Okay. Semilunar valves. So right, left, and anterior for pulmonary, right, left, and posterior for aortic. We went over that. So is this aortic or pulmonary semilunar valve? So the right and left coronary arteries arise from the right and left aortic sinus. So as the aortic sinuses fill with blood, the blood is automatically forced into the arteries. And you can see openings for right and left coronary arteries here. Okay. This will 100% be on your EPC exam. And it's just one of those things that you might as well learn it now because you're going to do it over and over and over for like every SPE and everything, EPC related. So, just in case they do ask you this on the anatomy exam, the mnemonic that I learned was PAMT. So left, right, PAMT. Or another one I've heard is ape to man. So you can go from right to left and straight down. Don't worry about Earp's point right now. All right, so stethoscope is placed over the left second intercostal space, just lateral to the sternum. Would be best positioned to detect sounds associated with which heart valve? So the answer to this is going to be B, so left second intercostal space. So if you use PAMT, you have to go left, more right. Does that make sense? So the answer to this one is going to be B, pulmonary. Okay, The heart sound best associated with the mitral valve, or associated with the mitral valve, is best heard at where? That's right, D. So I recommend kind of like relying on a mnemonic until this just becomes like ingrained into your brain. Okay, so fun slide. All right, so the fetal shortcuts. Um, this is a slide that she said you would at least have one question from it. So you can read what I have over here, but I'm just going to kind of start with a picture. Okay, so you have oxygen-rich blood from the umbilical vein. So it's oxygen-rich because it's coming from the placenta, which is associated with the mother. So the umbilical vein is carrying oxygen-rich blood, and it's going to travel through the ductus venosus and then hook up with the inferior vena cava, and it's going to enter the right atrium and pass directly to the left atrium through the foraminal valley. Okay, and then we have oxygen poor blood, and it's oxygen poor because it's associated with the fetus, and it's coming from the superior vena cava, and it's directed through the right atrioventricular orifice, and then from the right ventricle through the pulmonary trunk and to the aorta through the ductus arteriosus. Okay, so this is one of the bypasses. And that's really, the gist of what you need to know. Other than that, you need to know that the foraminal valley becomes the fossa ovalis in the adult. And then the ductus arteriosus becomes the ligamentum arteriosum. And the ligamentum arteriosum, which nerve is closely associated with that structure? This is making the connection. So left what? Left recurrent laryngeal, right? So this is making those connections. Make sure you realize this. Ductus arteriosus becomes the ligamentum arteriosum, and then the left recurrent laryngeal nerve is associated with the ligamentum arteriosum. So big connection there. And then also, okay, so you have what I said in words here. And then one last important thing about this image, why do branches of the aorta, or of the arch of the aorta, come off first and then the fetal blood is shunted into the aorta via the ductus arteriosus? It's because we want to make sure that the brain is receiving adequate oxygen first before we start mixing the blood. Because if we had deoxygenated blood being pumped into the aorta from the pulmonary trunk, your blood becomes less oxygenated here. So we want to make sure that everything up here, the brain especially, is receiving adequate oxygenation. Okay. I think I wrote down 2 more questions for you guys. So where do we find the ligamentum venosum in your donor? Do you guys remember talking about the ligamentum venosum? Right, liver. So you guys are thinking ligamentum teres. So ligamentum venosum is a little bit different. So ligamentum venosum is found between the caudate lobe and the left lobe of the liver. I'm sorry I don't have a picture here, but just if this is like you're like, I don't really remember that, pull out your atlas and look for the ligamentum venosum. So that's going to be between the caudate lobe and the left lobe of the liver. And then, so when you hear people say, have you heard them say obliterated umbilical vein? Have you heard that phrase? And you're like, if you're like me, you're like, what are they talking about? So right here, umbilical vein, obliterated umbilical vein is heading up to the liver. So this is the ligamentum teres. So remember the round ligament found in like the free margin of the falciform ligament? This is what they're talking about. Is that sort of making sense? Does that help at all? To try to put all of that together? Okay. Yeah, just, I know it's late, so if you're like, what on earth, come back to it again and, read through this slide and try to make all of those connections. Okay. All right, so the ductus arteriosus sometimes remains open after birth. When placing a clamp on the ductus, care must be taken to avoid injury to what important structure immediately dorsal to it? So I'm like hammering this point in. Like I know you guys are going to get this right on the exam. D, right? So what is the ductus arteriosus become? The ligamentum arteriosum. All right, so we got that one. All right. This is kind of something that you just have to study on your own. So what I used to help me was a small margin of great lads will show PDA in middle school, and that's to help, associate the vein that runs along with the artery. So small margin is referring to the fact that it's a small cardiac vein and the right marginal branch run together. PDA in middle school, middle cardiac vein, and posterior interventricular together, and then your LAD and great cardiac vein. Dr. Hermy, called this GLAD, so G and LAD, so that might be helpful too. And then make sure you know like the difference between a left and a right dominant heart. So if you're right dominant, your PDA is coming from the right coronary artery, but if you're left dominant, the PDA comes from the circumflex branch of the left coronary artery. Okay. Here's a way they could ask about coronary arteries on your written exam. So go ahead and type in the answer for this one. That is correct. Anterior interventricular. So if you go back and look at a picture of the coronary arteries, you'll see that LAD running towards the apex of the heart. All right. Okay, so you're attempting to suture the distal end of a coronary bypass onto the anterior interventricular artery. The surgeon accidentally passed the needle through the adjacent vein. Which vein was damaged? So this question you're going to answer by knowing which vein is associated with which coronary artery. Yes, the great cardiac vein. That was the easy one. Okay, so cardiac conduction system. Be familiar with this pathway. This is really the extent that you need to know, anything about cardiac conduction right now. She did also mention, she mentioned this kind of in passing, So the purpose of the moderator band is that it carries the right bundle branch of the conduction system to the anterior papillary muscle. And then if you have my old slides, I think Bree caught a little mistake here. So it should say, what is the function of the sympathetic and parasympathetic nervous system in regards to contraction of the heart? So, the heart, sorry about that. The heart has its own intrinsic firing rate, it sets its own pace, but the sympathetic and parasympathetic nervous system is going to alter the force and the rate of the contraction. So basically, it's going to speed it up or slow it down. Okay, another question. So, an elderly lady suffers a coronary occlusion and subsequently is noted that there is complete heart block. That means the right and left bundle branches of the conduction system have been damaged. The artery most likely involved is the right, so anterior interventricular. Okay. So let's go through some embryology. I have a lot of fresh practice questions for you guys. So I went through BRS embryo, and I pulled out all of the questions, related to intro to embryo and cardiac, heart development, that I thought were relevant to, what Dr. Gassler taught. Okay, so just to go over some highlights here. Okay, so on day 0, and I've had a lot of people ask me, when you list all these days, do I really need to know them? And the answer is, I would know, when fertilization occurs, so day 0, when implantation occurs, and then after that, you can just know it by weeks. So during week 2, what's happening? During week 3, what's happening? During week 4, what's happening? And if you can get that far, I think that's good enough for the exam, because I think when he got beyond that, he said something like, don't worry about this. I'm just adding it for completeness sake. So, know what's happening at least during the first 4 weeks. Okay, so on day 0, the sperm is going to penetrate follicular cells that surround the egg, and then it's going to release enzymes to begin dissolving the zona pellucida. And then you have cortical vesicles in the egg, and these are going to secrete proteases, so the zona pellucida becomes impermeable to other sperm. So basically, this just means that that egg is committed to that one sperm, and all the other sperm competing, now they're not going to touch it. Okay, and so fertilization is going to occur within 24 hours of ovulation, but you have to keep in mind that sperm can survive up to 6 days in the female reproductive tract. So if ovulation occurs within those 6 days, the egg can still be fertilized. And, of course, the longer the sperm is, in the reproductive tract, the less the odds are, but it can still happen. So, that's something good to know, to, figure out how you can counsel your patient, about the fact that, well, if you have sex before ovulation, it's still possible to get pregnant because, the sperm can survive. All right, anyways, moving on. Within the first 12 hours, you have formation of the zygote. So maternal and paternal haploid gametes are going to fuse to form a diploid zygote. And then the zygote is going to begin to divide through mitosis and form this ball of 16 cells known as the morula. And then the morula is going to enter the uterus and become the blastocyst. And the blastocyst is going to form, an embryoblast, which is the inner cell mass, which, eventually contributes to the embryo or the fetus itself. And then the trophoblast, which is the outer cell mass, which is destined for the placenta. And then within those two, you have a blastocyst cavity. So the trophoblast, or the outer cell mass, is going to invade the endometrial epithelium to form the placenta. So invading the endometrium is going to be the syncytial trophoblast, and then you also have the cytotrophoblast. And then the embryoblast, or the inner cell mass, is going to form a bilaminar germ disc. So, and that is made up of a hypoblast, which is like primitive endoderm, and an epiblast, which is primitive ectoderm. Okay, so by the time you reach week 2, we have what's known as the week of 2. So you're going to have 2 germ layers. So your embryoblast forming the hypoblast and the epiblast, and then 2 amniotic cavities. 2 cavities, which include the amniotic cavity between the epiblast and the placenta, and then the umbilical vesicle, also known as the yolk sac. And then you'll also have 2 placental layers, so cytotrophoblast and syncytiotrophoblast. So this is just a little bit of a repeat of this box, but putting it together in the week of 2. So remember 2, 2, and 2. And then also, the reason I have this highlighted is I remember being asked this at some point. It could have been in physiology, but it might have been one of Dr. Gassler's questions. So no, where fertilization should occur, so then the ampulla of the uterine tube, and then no, where implantation occurs, so most commonly in the posterior wall of the uterus. All right, and then I put this picture in here. If you want like one picture to study from, I think, this was the best one in his slides because it shows you everything. So syncytiotrophoblast, cytotrophoblast, the amniotic cavity, hypoblast, epiblast, so there's your bilaminar germ disc, and then the primary yolk sac. Okay, next, during week 3, we have gastrulation. So gastrulation is referring to the formation of the trilaminar germ disc. So when the epiblast cells invaginate and form the primitive streak, it's actually the epiblast cells that are responsible for the formation of the ectoderm, the mesoderm, and the endoderm. So the endoderm associated with the embryo is actually a result of the epiblast cells, and then the hypoblast cells, which is the primitive endoderm, is actually being pushed laterally or out to the side to form the extra embryonic endoderm. Okay. Next. I would definitely just have an idea, the ectoderm is contributing to, the formation of nervous tissue. The mesoderm is forming muscle and CT, or connective tissue. And then the endoderm is responsible for, also all 3 are responsible for epithelia, but, also gut and gut derivatives. So start getting an idea of, what type of tissue these structures are derived from. Okay, so neurulation. So it's going to be the notochord that forms the primitive streak cells in the mesoderm, and this is what's going to induce the folding of the neural plate. Okay, so you have the neural plate folds, and you have the neural groove forming the neural tube. It's going to be the remains of the notochord that form the nucleus pulposus of the intervertebral disc. So is the nucleus pulposus considered the jelly or the donut of the intervertebral disc? Yeah, right. It's the jelly. And then what's the other part? What's the donut surrounding it? Yes, annulus fibrosus. So nucleus pulposus, annulus fibrosus. And sometimes during first year, some of the stuff I was like, why the heck does this even matter? But when you start getting into herniated discs, understanding this is really important. So I promise that it's just not like, it's not for nothing. Like it eventually becomes like more clear why you're learning all of this. Okay. Let's see. I'm also going to ask you guys, what do neural crest cells become? The peripheral nervous system, right? So the neural tube becomes what? Right, and DRG. And then what does the neural tube become? Right, central nervous system. So keep that in mind. All right. So, segmentation, I don't really remember being asked about that on this exam, but just know that the mesoderm cells divide into 3 regions, paraxial, intermediate, and lateral mesoderm. So, lateral mesoderm is responsible for, parietal and visceral, so body wall and attached to the organ. And then intermediate is kind of everything in the middle, the kidneys and whatnot. And then paraxial is responsible for formation of all of the segmental structures in the trunk. Oh, sorry. Which part? I just saw your question. About neurulation or segmentation? Sorry, if you tell me which part to repeat, I will. Oh, okay. So neural tube, think CNS, neural crest cells, PNS, and the DRG. Okay. So on this slide, you want to know that between weeks 4 and 8, when organogenesis is occurring, that's when the body or when the fetus is most susceptible to teratogens. Okay, and those can lead to any major birth defect that you can think of. Just for time's sake, I'm going to skip over this. I don't really remember being asked anything about this on this exam, but you can read over that and just let me know if you have any questions, okay? All right, and then this slide is straight out of first aid. So a lot of helpful tricks to help you remember what is associated with each week. So week 2 is the bilaminar disc. Week 3, gastrulation, so that's where you get the 3 layers. And then 4 limbs and 4 heart chambers. So limb bud and cardiac development, gait at week 8, and then you can determine the sex by week 10. Okay, so here's some practice questions. How soon after fertilization occurs within the uterine tube does the blastocyst begin implantation? Right, so the correct answer would be E, by day 7. Implantation has started. So if you were going to know any specific days, I would say this one might be an important one to keep in mind. All right. Where does the blastocyst normally implant? And I know you don't quite know enough to answer this, but you can probably guess. Yeah, I know it's going to be divided between B and C. Yeah, so the correct answer is B. And the functional layer of the endometrium, that's the layer that's being sloughed off. The basal layer is the layer that's being regenerated during each menstrual cycle. Oh, actually, so this should be over B. Sorry about that. I'll fix that before I post the answers. Okay. Yeah. Did everyone get that? So the correct answer is B. All right, which of the following structures must degenerate for the blastocyst implantation to occur? Yeah, so the correct answer here is B. And if you go back to those charts, I have that mentioned under like the block that talks about implantation. So go back and look at that. Okay. Which germ layers are present at the end of week 3 of development? Yeah, just 1 second. Let's get through this one and then I'll go back. Right, so the correct answer is D, ectoderm, mesoderm, and endoderm. And what do we call this process? Gastrulation, that's right. Okay, let's go back here. Okay, so on this question, E is not correct because if the functional layer of the endometrium is shed, that means that the woman has started her period. So that's the layer, that's lost during, her 4 or 5 or however many day cycle. So if she's pregnant, we want this layer to be maintained, and you don't want it to degenerate because that probably means that she's having a miscarriage. Does that make sense? All right, let me know if it doesn't. You're welcome. All right. Which of the following components plays the most active role in invading the endometrium during blastocyst implantation? Yes, that is correct. To be the syncytial trophoblast. And if that doesn't make sense yet, go back and look at a picture of the syncytial trophoblast and see what it's doing. Okay. Which process establishes the 3 definitive germ layers? That is correct. B, gastrulation. The first indication of gastrulation in the embryo is Yes, formation of the primitive streak. Good job. All right, a little bit tougher question maybe. Which structure is derived from the same embryonic primordium as the dorsal root ganglia? Yeah, good job, you guys. Adrenal medulla, that's correct. Okay, I want you guys to read this one, and I bet you can get it right. I'm sure if you guys are a mom already, you're going to be all over this one, right? Right. So we're going to order a laboratory assay for serum HCG. Why would we not prescribe her the morning after pill? Yeah, but why does it not work? Right, so basically we're too late at this point. So I believe it's after 10 days. So serum is referring to blood. So after, right, yeah, implantation has already occurred. So serum is referring to blood. So if you're thinking like, well, that doesn't make sense. Like she hasn't missed her period yet, so it would really show up on a pregnancy test. If we ordered a blood test, um, it may show up at this point, whether she's pregnant or not. Okay. All right. Well, I gave that one away to you guys. Okay. So, at what location does the amniotic cavity develop? So that's within the epiblast. Okay. So at the end of week 2 of development, what is the composition of the embryonic disc? Yeah, so epiblast and hypoblast. Um, I want to say last year, one of his questions were really as simple as just knowing the difference between gastrulation and the formation of the bilaminar disc during week 2. So I know a lot of you guys are like really stressing about this embryo stuff, but I honestly think like if you put out the effort to study his lecture, um, yeah, you're stressing. Yeah, if you put out the effort to study his lecture, his questions are not that bad. Okay, the reason a lot of people miss them is because like they're like, oh, embryo, I'll back burner that because I'm not learning that in lab, and then they wait till like Saturday or Sunday to try to make sense of what's going on. Um, and you don't want to do that. So make sure right now, if you're lost, like try to start figuring out what's going on with these lectures because like you can definitely get his questions right if you just just like try to wrap your mind around it and get like the big points. And I think if you look at my slides, like I've tried to highlight what he's most likely to ask. And I think that these practice questions, like, they're not far from the type of questions that he asked last year. So, I didn't have BRS embryo last year, and I was looking at these questions, and I was like, wow, he must have a copy of this because some of the questions that he asks are pretty similar. Okay. All right, let's do heart development. So, let's see. There's no Anki for this yet. I honestly didn't use Anki for anatomy. Um, you could try to make your own cards, I guess, but just study the slides that I gave you. Go back and re-listen to his lecture. Sometimes, if it's something really confusing like this, if you listen to it a few times, like you'll pick up like bits and pieces each time, and it'll finally start to click, I think. Okay, so let's keep going for time's sake. All right, so inflow tracts and outflow tracts. So, this is pretty straightforward. So, inflow tract, you have your sinus venosus, you have a single atrium and a single ventricle, and then your outflow tracts are formed by the bulbus cordus and the truncus arteriosus. And you have common cardinal veins, vitellin veins, and umbilical veins all dumping into the sinus venosus. Okay, so on this slide, so you want to realize that, at this point, the sinus venosus, this is just a single atrium. So our goal here is to shift everything to the right. So we start having the blood coming in one side and going out the other side. And so you want to know that the right horn of the sinus venosus is going to form the superior and inferior vena cava, and then the sinus venerum of the right ventricle, and then the left horn is going to form the coronary sinus. And then the right half of the sinoatrial valve forms the crista terminalis, also contributes to the IVC and the coronary sinus valves. If he was going to ask you anything, it's probably going to be the right or the left horn. So just think about which side of the heart these structures are located on. So obviously, superior vena cava is on the right side, and then the sinus venerum, that smooth wall of the right atrium, on the right side. Coronary sinus is on the left side. All right, so down here, so as the left atrium grows larger, the pulmonary veins are incorporated into the left atrium. So this is why there are two pulmonary veins coming off each side of the left atrium. And the left atrium is smooth-walled because it's developed by those endothelial cells of the pulmonary veins. And I think he mentioned in lecture that the left auricle is the remnant of the primordial left atrium. So the left atrium has pectinate muscles, but the left auricle has pectinate muscles, but the left atrium does not. So the left atrium is smooth-walled compared to the right atrium where you find pectinate muscles. And then you have that crista terminalis, which separates the smooth and the rough-walled portion. So in the left atrium, you don't have that. It's all smooth-walled, and that's because it's developed from the endothelial cells of the pulmonary veins branching out here. Okay, so maybe not like super high yield, but something to know, keep in mind. All right, so this slide is straight out of first aid, and this is a really good slide to study from. So take a look at this. All right, next we have partitioning of the atrium. So if I was to guess, I would say he would probably ask you some question about this. So let's try to go through this. Okay, so over here, you have the septum primum. So this starts to grow down from the atrial roof, and then the foramen secundum, right here, begins to form as the septum primum grows down to the endocardial cushions. Okay, so within the septum primum, you have this foramen secundum forming, and then the foramen primum is eventually going to close. So it's eventually going to reach the endocardial cushions. So then next to the foramen primum, or I'm sorry, the septum primum, you have this septum secundum growing down next to it. And it's not going to be complete. So the incomplete septum secundum is what's going to form the foramen ovale. So it leaves this opening called the foramen ovale, and then the septum primum forms a one-way valve over the foramen ovale, and it allows for blood to be shunted from the IVC directly to the left atrium. So I think this is a little bit more clear on the next picture. Okay, so this is putting it in the context of birth. So after birth, once blood flow has been established through the lungs, the pressure in the right atrium is going to drop, and then the pressure in the left atrium increases. And this valve here, that is the septum primum, it's going to snap shut, okay? So it snaps shut, closing off the foramen ovale, and then in the infant and in the adult, this is now known as the fossa ovalis. All right, any questions about that? So I would try to understand how this process works. Okay. So partitioning of the tracts. So you have partitioning of the inflow tract. So dorsal and ventral endocardial cushions, they grow towards one another, and then they fuse to form the left and right AV valves. So you have the endocardial cushions contributing to the formation of the AV canals, and then the outflow tract is formed because the bulbar and truncal ridges, they fuse to form the aortical pulmonary septum, and this creates an aorta and pulmonary trunk. So the thing to understand here is that you're going to get this spiraling of the aortical pulmonary septum, and then you have each ventricle becomes aligned over the correct outflow vessel. So the aorta eventually is lined up with the left ventricle, and then the pulmonary trunk is lined up with the right ventricle. All right. Okay, so septation of the ventricles. Okay, so this slide is not bad at all. So the muscular IV septum, in the beginning, it incompletely separates each of the ventricles. So you get this interventricular foramen initially, and then this is closed by the formation of the membranous interventricular septum. All right, and then, so what is the most common heart defect? This is a patent IV foramen, and that occurs because the membranous IV septum does not close that interventricular foramen. So this stays open. But if development occurs correctly, then it's going to be closed off by the membranous IV septum. So that's the most important part of this slide. All right. So atrial septal malformation. So you can have a patent foramen ovale. So this, of course, is going to allow mixing between the left and the right atria. And this is basically, just a result of any problem with, the forming of the foramen ovale. So, you can have excessive resorption of the septum primum, you don't have a septum secundum form, or, maybe both of these are missing. And then, once the baby takes its first breath, there's nothing to snap shut and nothing to seal off, left from right atrium. So I put this in bold and red because this was the only thing I believe in his presentation that he took the time to circle in red and really make a big deal about. So ventricular septal malformations are the most common heart malformation, and they're going to allow for mixing of blood between, sorry for my typo, left and right ventricles. And then also important to know is that a membranous septal defect is going to be more serious because it's not going to correct itself on its own. Okay, and then I put this slide. So this is what happens when this IV foramen stays open. So you have blood from the left ventricle being shunted to the right, and then the right ventricle is working extra hard to get all that blood pumped back this direction. So you get what's known as right ventricular hypertrophy. So right ventricular hypertrophy results because of this membranous septal defect in the IV septum. Okay, so he definitely asked us a question about the tetralogy of Fallot last year. All right, so I'm going to go on to this slide. Okay, so tetralogy Fallot starts with a pulmonary stenosis, okay? And that's going to lead to 3 different compensations because of that pulmonary stenosis. So the first one is going to be a ventricular septal malformation. And, again, this results from, that membranous IV septum not forming. So you get blood from the left ventricle being shunted over to the right ventricle, and that's going to give you hypertrophy of the right ventricle because all this blood here is coming over here, and then the right ventricle is working extra hard trying to get it back out. So hypertrophy, meaning the right ventricle, gets bigger or enlarged. And then also you're going to have an overriding aorta. So I would definitely remember the 4 things that contribute to tetralogy of Fallot. So tetralogy meaning 4, what are the 4 things associated with tetralogy of Fallot? This is, very high yield as far as your exam, as far as for boards, it's going to keep coming up. So I would be surprised if he doesn't ask about this one. Okay, persistent truncus arteriosus. So basically, you have no separation of blood flow. So there's no separation of the outflow tracts, and you can see that right here, persistent truncus arteriosus. Okay, and then unequal division of the truncus. So this occurs, when the pulmonary trunk It's fed by the ductus arteriosus, and it usually involves a ventricular septal malformation. So the right ventricular blood gets into the aorta. Okay. And then here we have transposition of the great vessels. So this one is pretty easy to understand. So the septum is going to be straight rather than the spiraling of the aorticopulmonary septum that we talked about. So basically your two outflow vessels are positioned over the wrong ventricle. All right, so practice question time. The most common interventricular septal defect seen clinically is what? B, that's correct, membranous VSD. Okay, which of the following clinical signs would be most obvious on examination of a patient with either tetralogy flow or transposition of the great vessels? Yeah, defect, malformation, same thing. All right, so I have one person that's correct. So the correct answer here is cyanosis, and that's because so when you have transposition of the great vessels, you're getting mixing of oxygenated and deoxygenated blood. So you're getting less oxygenated blood delivered to the body. So, your infant or patient or whatever is becoming cyanotic. All right. How soon after birth does the foramen ovale close? Yes, it's correct. Immediately. That one wasn't too bad. Okay. The coronary sinus is derived from which of the following? Yes, so one for bulbous cordis. So the correct answer on this one is actually E. And remember, the sinus venosus is that primitive right atrium. So that's going to be associated with the coronary sinus. Does that make sense? Let me know if not. Okay. A muscular VSD is a cardiac malformation that involves which of the following septa? Yes. Good job, you guys. Interventricular septum. All right. Transposition of the great arteries is a cardiac malformation that involves which of the following septa? Yes. Good job. A is correct answer. All right. posterior mediastinum. For time's sake, we've already been over this slide. The sternal angle, so remember, you can use this to find rib 2. It divides the superior and inferior mediastinum. It's a landmark for the bifurcation of the carina, or where the trachea bifurcates, and it is indicative of the beginning and the end of the arch of the aorta. All right, we're getting there, you guys. Okay, so the esophagus. I think we've talked about the majority of this. We weren't asked anything about this last year, if that helps you at all, FYI. Don't know about this year, but weren't asked last year. Okay, so the esophagus receives its blood supply from, the thoracic aorta, bronchial arteries, and ascending branches or esophageal branches of the left gastric artery. So the left gastric artery is a branch of what artery? Not common hepatic, the celiac trunk, right? All right, so somebody type out 3 main branches of the celiac trunk real quick. Splenic, common hepatic, left gastric. Good job. Okay, we talked about what passed through the hiatuses. All right, we've talked about the fact that the vagus nerves pass posterior to the lung roots, and then the phrenic nerve passes anterior to the lung roots, and then this left recurrent laryngeal nerve passes inferior to the arch of the aorta. So don't forget about that when they tag it. All right, you've seen this picture. I'm going to skip this. And I think hopefully this review is becoming clear how many times they repeated stuff. So like this left recurrent laryngeal, you've seen it 100 times. Like it's going to be a big thing on the exam. So like I think this review is kind of hopefully making some of those big things clear. Okay, so you're a medical student on your 3rd year rotations watching a surgery to remove a thymic tumor from the superior mediastinum. The surgeon asked, what important nerve curving posteriorly around the arch of the aorta should we avoid as we remove this tumor? Because your tutor prepared you well, you say a branch of... Yes, the left vagus. I was like, oh no, apparently I didn't prepare you well. Yes, C is correct. Good job. Just when you think you're off the hook, the surgeon says, what is the name of that branch? A, left recurrent laryngeal. Good job. Okay. Next we have the thoracic aorta. So, let's see. Okay, so a couple important things. Make sure you realize that the aorta is located to the left of the vertebral column when you're above the diaphragm. Then when you're below the diaphragm, it's located anterior to the vertebral column. So if you know these types of relationships, like 1, it's going to help you with your imaging, and then 2, it's going to help you in the practical, because there are some things, like as you are realizing, some things are only on the left side, some things are only on the right side, and so on. Okay, so branches of the thoracic aorta, I would only worry about these 3. So posterior intercostal arteries, the superior phrenic arteries, and then the subcostal arteries. So this should say abdominal aorta. If you want to correct that, yeah, so abdominal. And I'll fix that before I post the answers too. Sorry about that, so abdominal. Okay, azygous system of veins. Okay, so here's another place. So they've repeated this several times, so you gotta know this, okay? So azygous vein on the right side, hemiazygous on the left, and then accessory hemiazygous in some people. They tagged the hemiazygous last year, and you knew it was hemiazygous because you could see it crossing over. And crosses over at about the level of T9. So if you see something like that in the practical, you're going to call it hemiazygous. As far as like exactly which levels they drain, I don't remember being asked that, but it's here just in case. Okay, so an 8-year-old boy is found to have a midline tumor of the thymus gland that is impinging posteriorly on a blood vessel. The affected vessel is most likely what? Yes, that is correct. The left brachiocephalic vein. So good job for getting that. So Dr. Hermy likes these type of questions where she'll test your knowledge of relationships in the lecture exam. Okay, so this is a really good example of something she would ask. So you have to be able to visualize like how everything is layered and then what's on the right side, what's on the left side. You have to be able to visualize that in your head because if they ask that on the lecture exam, you're not going to have the body right there in front of you to look at. But good job on getting that one right. Okay. See, we talked about the thoracic duct. So another thing that's been repeated a lot. You want to know. So for some reason, I feel like this might have been a question where the thoracic duct is draining. So it empties into the junction of the left subclavian vein and left internal jugular. Okay, and it's going to drain everything below the diaphragm and on the left side of the body. So what's draining the right side? Really simple, just the right thoracic duct. Okay, so in obstruction of the superior inferior vena cava, venous blood is returned to the heart by an alternate route via the azygous vein, which becomes dilated in the process. Which of the following structures might it compress as a result? Think about your relationships here. Yes, that is correct. It's D. All right. Okay. So, sympathetics versus parasympathetics. So, when we do GI on Tuesday, like I'll get into the splank next, but as far as the thorax is concerned, I'm just going to cover that much for tonight, okay? So you want to know the location of the preganglionic cell body. So if they ask you that in the sympathetic nervous system, that's going to be in the intermediolateral cell column from T1 to L2. And in the parasympathetic nervous system, that's cranial nerves 3, 7, 9, 10, and then S2 to S4. So this is going to come back, a million times. So 3, 7, 9, and 10. Make sure you know which cranial nerves are carrying parasympathetics. Okay, so how do preganglionic parasympathetic fibers leave? Actually, you know what? I'm going to skip this for now, okay? And we'll cover this tomorrow night. All right? I think it'll make sense when we do it all at the same time. Okay. Which structure contains postganglionic sympathetic fibers? Yeah, we're kind of getting a lot of different answers on this one. So the answer is actually D. So it's the ulnar nerve. Okay. So the vagus nerve contains parasympathetics. The sympathetic trunk contains preganglionic sympathetic fibers. Okay, and then the greater thoracic splanchnic nerves, those are also preganglionic sympathetic fibers, because remember, they're not synapsing in the chain yet. Does that make sense? And then the recurrent laryngeal nerve, that's a branch of the vagus, so that can be right. All right. So, good, okay. So, thorax imaging. Okay. So last year, I'm pretty sure we were asked about the different densities. So air is going to be least dense, and then metal most dense. And I think it was a question like, like rank the following from least to most or most to least, so that's easy to kind of make a multiple choice question out of. Okay. So this x-ray is hung correctly because, the heart is on the left side. And then we have, anterior, posterior rib. This is posterior. All right. So if you asked about the carina, remember that's at rib 2. And then the lingula. So a lot of people want to say that this is on the left lower lobe, because it's the tongue and they think it's hanging down, but it's actually part of the left upper lobe, so don't let that trick you. I'm pretty sure this one was used on the exam last year. Okay, so know your main vessels. So your BCS and then your superior vena cava. Or he could also use like an image like this. So I think, something to do with BCS, he used an image and, how'd you label that on the exam? Okay. So this one, so he used this picture on the exam last year, and I got it wrong. But I think if I had stopped and thought about it, so the right ventricle, remember, is the anterior surface of the heart, and then the left atrium is in the back. So over here has to be the right ventricle, or I'm sorry, the left ventricle, and then the right atrium. So, if he happens to do this question again, just a heads up. All right. And then you guys can look at this question here. So make sure that you can name each of these. And if you know the surfaces, then I think if I had put two and two together, like I would have got this right. Like if I knew what the anterior surface was, then I would have called this right ventricle. Alrighty. Coronary arteries. I would look at this one because I think this would be hard to figure out, like unless you had studied it. You know what I mean? Like you couldn't really necessarily rely on just knowing your relationships. So I would take a look at this one. But as far as Dr. Chestnut goes, if you, just study his slides, like study all of the images he gives you, like make sure that you, occlude each label. I don't know if somebody's like made an Anki deck of these or not, but you can just I don't know, like scribble over them in Notability or quiz yourself that way. So anyways, what I'm trying to get at, sorry, so what I'm getting at is, if you know the images he gives you, like if you put up the same image and it was blank, if you could label it, like you would be fine. And he's not going to put an arrow on anything that looks fuzzy. So like the chest x-rays, it's going to be like an obvious landmark. It's not going to be something that, yeah, you're welcome. Like it's not going to be something that, you know what I'm trying to say. It's going to be obvious. It's going to be something that, we as like first and second year medical students can do. Like he teaches a lot in second year too, and he's very fair. So what I'm saying is like, don't get too stressed about his lectures. You study his slides. I think he reuses a lot of the same images out of his slides. Okay, so we are done. Okay, I've noticed a few typos here and there, and I like greatly apologize for this, but like as you can imagine, like I'm trying to study second year stuff, and this ended up being 186 slides, so I did make some boo-boos. One here, this should say sympathetic, so sympathetic fibers. I'll go back and fix that, not parasympathetic. Don't get confused. I'll fix that. The few typos I had here and there, I'm going to fix those. I think I pointed them all out to you though, so I'll get those fixed and I will post this with all the answers and all the corrections. So I'd recommend, downloading that corrected version and then you can study from it and have it saved or whatever. All right, so thanks for hanging in there with me. I know that was a long one. Let me know if you have any questions. Yeah, you are very welcome. Well, now you know why I make so many typos, because I'm usually like furiously like putting these slides together and stuff, and yeah. So if you see anything that looks like wrong, trust your knowledge. It's probably just me making a typo. And, feel free to point those out to me too. I'm definitely not above making mistakes. Yeah, you're very welcome. Thanks for hanging in there. If any of your classmates ask, you saw me try really hard to record this, so hopefully that recording is still going. And give me a day or so to get everything corrected and a nice copy posted on the Google Drive. And I also will get this recording uploaded to YouTube. Oh, and like fun fact, I didn't know this until medical school, but you can double speed YouTube too. So you can put YouTube on 2 times speed. If that's news to you, it was news to me. All right. All right, everyone, have a good night. I'm going to get out of here and go get a drink. All right, good night.